Seat. Greatly appreciate it. It's wonderful to see everyone here this morning. My name is Laura McClellan, and I am the chair of the Research Committee of the Healthcare Management Division. And so I have a great privilege today to introduce to you our plenary speaker, as well as our 2017 Keith Provan Distinguished Scholar, Dr. Douglas Wholey, who's of the University of Minnesota and the Division of Health Policy and Management. But before I let him take the podium, I wanted to describe briefly a little bit about why he is so incredibly deserving of this award. So we had a wonderful set of applicants, but our job was made very easy when we received his nomination from two of our past Provan Award winners, Dr. Stephen Shortell and Robert Burns. And it was quite apparent, it was very much a unanimous decision that Dr. Wholey would indeed be our recipient. And there are many reasons that I could tell you as to why he is so deserving, but I wanted to just give you a brief snapshot. So he is currently at the University of Minnesota. Prior to that, he received his PhD in the very beginning of his career from the University of Berkeley, studying under the papacology giants, Drs. Freeman and Carroll. After that, he had appointments at Carnegie Mellon as well as at the University of Arizona. And along the way, he has made such impactful contributions to our field. In the earliest days, we see very significant contributions to our understanding and the research on managed care, specifically HMOs, using the organizational forms framework from his papacology days. And so for those of you who are less familiar with his work, you may think that we are honoring today a macro OT scholar, and that is only partially true. Because if you look at his CV and you look at the literature, what's so impressive is the breadth of his research. Some of his most recent work is on the use of teams in healthcare organizations. And so what you think of as in the beginning as an OT scholar, what we have now too is a very micro OB scholar as well, which is incredibly impressive in itself. What's also very impressive is not just the breadth of his research, but also the depth of his research, the theoretical contributions that he's made, which is very much reflected in the outlets in which he has published. We see his work in some of our top-tier health services outlets like HSR, Health Affairs, MCRR, but we also see it too in some more of our disciplinary journals and the management and org journals. He is published in Administrative Science Quarterly, Academy of Management Journal, Academy of Management Review, OBHDP, Journal of Organizational Behavior. The list goes on, but it doesn't stop there. He is also published in the prestigious sociological journals, ASR, and the American Journal of Sociology as well, very much reflective of some of his early training in sociology. But we also see that he continues to push the envelope, and we have such sophistication in his theoretical contributions. The methodological rigor is quite impressive, and he is also published in the prestigious Journal of Health Economics too. Feats that very, very few have ever achieved in their career. It is rather astounding. It's also coupled with the fact that he has received numerous grants from excellent funding sources like the Robert Wood Johnson Foundation, as well as NSF, and he has also served on a number of editorial boards at some of our best journals in the field. So when you look at the culmination of his career, impressive is probably an understatement. And I think a better word to choose is inspiring. And so it is with great pleasure, and it is also with great honor that I introduce to you Dr. Douglas Wholey. Thank you, Doug.
Thank you. So thank you. It's really an honor to receive this award because when Rob called me up about this, I said, oh, Rob, I know there's a lot of people I think that are really deserving, that are really good people. And so to be chosen for this is really amazing to me. So I say thank you very, very much. First thing I'd just like to do is a Keith Provan Award. I'd like to remember Keith, okay? The theme of this year's conference is interfacing, right? Is that Keith? Right? Between public nonprofit, between healthcare management, contributions to org theory, contributions in social network theory, working with Patrick Kennis and others, right? Keith was an amazing person, did amazing work with social networks. But I think one of the things that always impressed me about Keith was the driver. He's always seemed to me to be somebody who's interested in doing this research to make the mental health care system work better, to make interorganizational systems and collaborations work better, in the goal of delivering better care for people, right? So Keith always seemed to me to be driven by the problem of improving outcomes for people, as well as making a very strong theoretical contribution. And to me, that's where a division like HCM really fits in to academy management. It's that blend of practice and theory done very well, okay? And Keith is one of the best that has ever been at that. I want to say thank you to Rob and Steve and Laura, and I found out who the rest of the selection committee was a few moments ago. Thank you very much. And I also want to say thank you. In the one sense, you can look to say, Laura said very nicely about what I've done, and I will go, oh no, that's Katie helping me. That's John Christensen helping me. That's so-and-so helping me. And so I will point to all the people that have helped me, and I've had the privilege of working with over the years that I've learned from and that have pointed out things to make my work better, okay? I also want to make apologies. If I don't reference you during this talk, I don't mean to slight you, okay? There are a lot of amazing people, okay? And so, I mean, I looked at my doctoral dissertation as none of the ideas were mine. I just assembled a bunch of different ideas. The only thing I did was organize them in a way that was sort of useful, okay? So all the ideas I remember, I can tell you where the ideas came from. Presentation structure, or sort of, this is from Laura's charge, my background and contribution, and I'm going to sort of describe that in terms of how my career unfolded. I'm going to give you a couple reflections on our craft, and then opportunities for new contributions I think we should be able to do. Theme, serendipity and data and colleagues. Okay. Subtitle, knowing where you are going when you get there, which is right now. And so I couldn't have predicted this. I have friends that are very organized and goal-directed. I just know what I don't like to do, so I end up somewhere. Okay. Papers guiding the presentation. First one is Herb Simon, Architecture of Complexity. We'll come back to that one. Core of Complexity Science. And to me, it's a must-read. Jim March, Science, Politics, and Mrs. Grunberg. How much should we get involved with policy? And the line is, if you think all the time about avoiding the politics, you'll be involved at just the right amount. That's what Mrs. Grunberg says. Martha Feldman and Wanda Orlikowski had a great paper about theorizing practice and practicing theory, which I think is really good for if you're worried about applied work and how people work, how your routines are constituted by your daily practice, which creates the setting that you work in, and they're mutually constituted. I think it's a really great paper trying to express where I'm going in my work. Recently, John Matthew had a great paper that I really enjoyed in JOB, The Problem in Management Theory. And I'm going to come back to some of these as we talk today. So they're sort of informing the thing. Background and contribution. My interests are, and as I tell Rob, if I had my druthers, I would have started out doing labor markets and careers and how labor markets are organized, because I always wondered why some people had jobs where they started with a firm, they kept moving up with the firm, and they ended up at a high point, why other people flitted between firms, why labor markets were organized, and what's the mix of organizations and status attainment. And then the second topic that came for me is, having worked a number of years, what makes work win-win, win-win? individuals get the job. You enjoy going to work. You thrive. You create value for your customers, for your patients, and you create value for the organization and for society. How do we get that done, right? How do we get those types of jobs? And the interesting thing is watching the literature on burnout in physicians now. Not all work that physicians do is burnout. Caring for patients isn't work. It's what they do. The bureaucratic stuff might be work, might be a hassle, might be imposing on you and all the EHR stuff, but caring for a patient who gets well, or caring for any patient and helping them, that's what you do. Okay, and as an academic, it's sort of like working with students, right? It's what we do. It's not work. It's our job, okay? And my goal has always been to understand how theory and research help us address the first two. And my goal has been, to me, is if I can publish in a mainstream org journal, I have that. I want to publish in the mainstream health services research, and if I have research that directly talks to mental health practitioners, I want to publish in the mainstream journals that they read, so I have the impact there. So I'm always setting up my research in hopes of hitting really top-notch journals. Doesn't always work, but it starts out that way. And then the other one is maximizing serendipity. My whole career, and I'm not going to generalize from where I've gone. I worked as a systems analyst programmer for 8 years, so I could push data around really well. That has served me very well in my life. I have worked with very large data sets. I've pushed data around. I've organized data. I've run information systems programs. It's given me a competitive advantage. And it also is a way of thinking that I think is useful. Okay, so the second on this, my PhD was in organizational behavior and industrial relations. I did a dissertation on lawyers and law firms. Yes, my advisor was John Freeman. I didn't do an ecology dissertation because I didn't see something I could do distinctive in ecology at the time. And I wanted to study lawyers and law firms. One reason is that I had a friend who was a managing partner in San Francisco law firm, and he'd take me out for very nice lunches. Okay? And I'm interested in causal mechanisms and context. And how do we explore and exploit at the same time through finding good colleagues, through watching the literature, through watching for unique data. And that's going to be the story of how I came to do healthcare. So at the University of Arizona, I showed up there having done my dissertation. John Christensen was on the selection committee. And then the next year, after I came, we hired Rob Burns. And Rob Burns came and he did a presentation on health maintenance organizations. And I said, oh, that's quite interesting. I had never heard of them before, okay? And so I went up to him and I talked to him. And then I went over to Christensen's office. And Christensen had these interstudy directories from 1976 on that listed all the HMOs. And I said, oh, that's what organizational ecologists like. Can I look at them? And he actually gave them to me. It was very nice. So I have a full collection. And then I said, oh, this is really interesting. First of all, this is an industry that's changing very quickly in a very heavily institutionalized environment, right? That has strong policy interest, right? Not too often as an organizational researcher do you get those three. Now, the extra is they're basically two different types of organizations, right? Group type, which are, the Kaisers, group health, the health partners, and the IPAs, right? Independent practice associations, right? They compete in different ways. They have different competitive advantages. And at that point, you can say, which communities will they enter? And so then you can start to look at how professional and corporate interests affect the formation of HMOs in communities, right? So you're integrating theory on professions, theory on the corporate state, as well as using your organizational ecology to do that. And then, by the way, you get policy implications about how you should set up systems, how you should encourage firms to organize to get what you want for a policy implementation, right? And that also leads into a paper on organizational failure, because that's what ecologists do, right? But then you get the contrast between the group and the IPA type for different effects. So that gave a very good paper, and Rob and I, in the meantime, did a paper on the transitions between types of HMOs. Now, the neat part there is I started going, these were the days before the internet, right? So I had a pile of newspaper clippings that big on HMOs. I was going to borrow books from everybody, and Christensen was there, and so I could go ask John all sorts of questions about managed care. And he'd be really helpful to me in understanding what's going on. And we also went to the National Association of HMO Regulators, which was really cool. Those regulators really knew what they were doing, and listened to their discussions. And at that point, I ran into the financial data that is collected by every state. And the state regulators were pretty good. National HMO firms wanted to file data to say, here's our national data, take that. And the state said, no, we don't want the national data. We want your data for this state, because if you go out of business in this state, we're worried about your reserves in this state to take care of our clients. Okay? And so the data was actually really good. It was audited, validated. The first place I got it from, I said, I'm a poor assistant professor, take pity on me, and they gave me 5 years worth of data. I was amazed. I had to pay for the rest of it. And I collected it, and the plus is, because I was working on coding the data and doing all this, I learned the data really well because I was going to the NAMOR meetings and the National Association of Insurance Commissioners. I could talk to people about what the data really meant, what it really measured, what was good, what was bad, what to ignore, right? And that led to a whole series of papers that colleges typically don't do on looking at the performance, what's the effect of competition on HMO premiums, which Roger and John and I did. What are the scale and scope economies in HMOs? So we probed down into the performance arguments that you see in The Ecologist. And that worked off of sort of serendipity. I never knew about HMOs, much less the interstudy directories when I started, and that led me into the financial data. Okay, that was great. Lucked out on that one. Rob is interested in hospitals and physician relationships. You know, and it turns out Arizona, back in the 80s, was one of the first states to collect data that would have physician identifiers in their hospital discharge data. And Rob and we both figured out very quickly this could be advantageous for doing health services research paper. And so we started off doing volume outcomes papers. And here again, it's lucky because, as my friend Mike Finch tells me, we did one of the first cabbage analyses at the beginning of the development of cabbage when they were still learning by doing, so we got good volume outcome relationships. 20 years later, that relationship's gone, okay, because people had learned what they were doing and trained it in medical schools. Because we had physician data, we could do conditional choice models for hospitals. That has actually become an argument about using distance as an instrumental variable in a number of models. And we developed models that I thought were fun about how fast physicians change their practice between two hospitals. So I tend to approach the world modeling. Rob approaches it as the hospital-physician relationships, and we worked really well together because I'd come up with my crazy model. He'd help me frame it into the hospital-physician context. And so both these two, I don't do these without Christensen, Feldman, and Burns, right? And other people like Susan Sanchez, okay? I had a role in organizing. Carnegie Mellon went to in 1990, and I worked with Sarah Kiesler, and we worked on the information systems programs. We organized our students into teams, and what was great about this job is Sarah and I kept trying to predict why some teams perform better. And you know what we learned at the end? You can organize all sorts of different ways, but as long as you do it in a consistent configuration, you'll be successful. So you can be very hierarchical and centralized. Just make sure you keep doing that. There was even what I call a Zen Center team that everybody did all the aspects of the project from beginning to end. And they all coordinated very well, okay? But they kept consistent to their equality of work and their democracy, right? Which made it really difficult to get a paper to publish to say what works. And you go, well, lots of things work if you do them right. It's hard to get that through a journal. And I did have a couple papers there and started work. And this also led to the work on the teams on shared mental models and choosing work group members with a couple people there. So at Minnesota, by the time I got there, I looked at the HMO work and I said, that's a ball and chain. There isn't much more to do, not much more interesting there. So what can I do that'll be fun? And then I started really working on teams. And I had a sabbatical at the National Primary Care Research and Development Center in Manchester. And then they hired me as a visiting professor. And I kept working with them about clinic organization. It was great when I got to Manchester. One of the people there said, "Oh, that won't work here. That's only done for America, only works in America." And you know, he invited me to the clinic one day, and patients in England are just like patients in the United States. They show up, my nose is stuffed, my back hurts. Can you fix it, doc, right? There is one difference, because the doctors there had to room their own patients. They did not have any medical assistant. Okay, but actually that was a nice way for the doctor to connect with the patient. So that led to a lot of interest in how clinics are organized, and there's one project I had there that nothing got published out of. I was looking at social networks and clinics, and the conclusion I came to is the same one that I came to with Sarah Kiesler. There's all sorts of ways to organize them. You can make them all work well if they fit their local context and they're managed consistently. It's a configurational approach. It's not a main effects approach. Okay. Then David Noak, Jiju, and I, and a bunch of others at the U in Minnesota, started work on the assertive community treatment teams. We've had some publications on that and on teamwork, how to measure teamwork in teams. And we're still doing other things. We're finishing off a paper on social capital, and I have another one on positive and negative affect that we're working on. With Katie and with Joanne Dish, a nurse, worked on a paper on chronic heart failure teams in the VA. And that was for interdisciplinary nursing program. Okay, and then there was a Care Guides program that was an implementation of a layman in practice, and then there's a healthcare homes evaluation for the state. Now, the best part of all of these is I got to not work. I got to go hang out at clinics, right? And I got to go talk to providers and practitioners, right? And we do structured interviews, and I'll come back to that as one of the puzzles I've run into. In the healthcare homes, we're still finishing up a paper on why they transform and they don't. And along the way, I worked with Ira Moscovici on rural health and did a paper on public health systems, how you organize interorganizational networks. Parts of the story is funding was available. Okay, all right, I'll do that. Good partners like Joanne Dish were available. And there were good and interesting topics. And part of the public health system is I wanted a road trip. I wanted to go to rural communities in the South and see how they organize their public health systems. What the heck? I hadn't been to Kansas and Arkansas. I wanted to go there. Okay, so there's a subtext to all of these things here. Now, and along the way, I want to give a shout out to Steve Mick. Okay, and there's two papers that Understanding Healthcare Markets, Actors, Products, and Relations. That was in Steve's volume. 2002. That one started out with Rob calling me saying, gee, I've been asked to write a paper on what do sociologists have to say about how markets work. And he said, would you like to do this? And since the deadline was really far into the future, I'm a sucker for that. And I go, oh yeah, sure. And then after we hung up, I asked the question, well, really, what do sociologists have to tell economists? And then I'd say, well, I'll take this theory. No, that's just warmed over economics. Take that theory. No, I can do that with economics very well. And so it took a long time to figure out and puzzle out why would an economist, what could we tell economists that might be useful to them? Okay, and we basically came to a Weberian perspective. Okay, just went back to Max Weber, he solves everything. The Managing to Care is done, it was built out of our ACT study, and it was a little bit broader and looking at how clinics are organized and care management teams, and it's also using Eleanor Ostrom's ideas. If you think of a clinic, one version of it has these little teams, often of providers, a physician and an MA working together, supported by a care coordinator who supports multiple different physicians, right, or a care guide. a lab, right? Maybe imaging if you have imaging facilities, right? So it's a common pool resource type of situation, that there's a set of common resources that are shared by everybody, right? The care guide or the care coordinator, the labs, right? And how do you organize that effectively? And out of the care guide project that Katie and I were doing interviews, I remember one clinics where the care guide said every physician is their own cowboy. You have to deal with them their own way. Other clinics, the care guides would say it's all standardized, we all interact the same way. And then you start to ask, how do you organize common pool resources? You could call this a multi-team model if you want to do that literature too. And how do you organize that effectively at the clinic level? And we're still puzzling through that one. And that's basically what a medical home is. Okay, providers being supported by various people. Some reflections on our craft. What we do, our activities, our journalism. We go out and we interview various people, what's happening in your local ACO right now, and descriptive observational surveys and studies of what's happening in the field. Now, one of the interesting parts is some of those get funded pretty easily because they're very easy for policymakers and grantors to know about, right? And they give you things that tell the story of what's happening now, done to a fairly good, sophisticated level. People will pay you for that. Okay, that's a product. Then we get policy evaluation. Do ACOs work? What is their impact? That to me is sort of the first two with a little bit more heavy-duty statistics in it. Okay, you're saying, I have an intervention, I want to understand how this, if this intervention had an effect, I'm modeling it. And so it's fancy journalism, fancy descriptive study, okay? And I mean, when I say fancy, I mean fancy, because the methodologists here are really sophisticated. Only on the right-hand side do we get to science and engineering. And to me, that's partly where I've been trying to orient myself, okay? The first three get money pretty easily. I think it's harder to get funding for the science and the basic science and the engineering, and much harder to get funding for that. Science, and this is from John Matthew, and he quotes Stahl and Sutton, which I think is a great quote. Theory is about connections among phenomena, a story about why acts, events, structures, and thoughts occur. It emphasizes the nature of causal relationships, causal mechanisms, identifying what comes first as well as understanding the systematic reasons. In other words, theory is about the black box. Why do ACOs work the way they do? What would you say would be a good way to organize an ACO? Okay, and Feldman and Orlikowski have the idea of multiple constitution, that things are they develop, the institutions you work in, the routines and your behavior evolve together. They're not one causes the other, but they're a configuration. So again, it comes back to configuration. Theory is important because it's what accumulates. And so if you look at Ray Posson's and Nick Tilley's work on realistic evaluation, theory is what you carry from site to site to site. And then you ask the question, how do you implement these incentives in this setting or that setting? How does the context affect the way these incentives work? And that abstraction is really what we're aiming for to develop forward. And to do that, you have to start with the OB, the OMT, the other theory, use it to inform our study of healthcare organizations. And I think healthcare organizations are really such a rich environment to study these things are. We can feed back into core org theory very easily, and you see that in a lot of very good publications in org theory. Engineering, okay, theory is not, and this is, Matthew quotes this, referencing concepts, okay? Building little diagrams with arrows, okay, and estimating models. It's thinking about what really happens. It's not, and Richard Feynman has the term cargo cult science. I was doing a presentation to a group once, and I was doing risk adjustment, and one of the people in the group said, it is really great that we're doing science here, and I'm standing up there going, no, I'm running models to estimate a measure for you. I am not explaining to you why things work the way they work, which is what science is. But people equated all my fancy methodologies to science. That's not science. Methodologies are things we use to help us understand what's happening. Okay, they're our handmaiden. It's not, we have to be skilled in them, but it's not our core essence to me for science. And engineering to me is taking what we know from the science, right? And saying, how would we build things? And so, should we be able to answer the question, how would we structure an ACO? If you're an org theorist, I think you should be able to give a very good shot at that very quickly. Okay? So some observations over the years that have kept me alive of thinking of causes of effects and effects of causes. Causes of effects. If you've ever had a bad rash that you're really scratching and it really hurts, right? What do you ask yourself? You ask, what's caused this rash, right? Was it that new prescription the doctor gave me 2 weeks ago? I'll take away the prescription, right? Effects of causes are to say, it was that prescription he gave me, did it have this effect, right? In a way, what we do in publishing is we're rewarded for studying effects of causes, right? Managers care about causes of effects. Here is what's happening. I could ask on our healthcare system, why is our healthcare system so expensive? And we're going to ask about a root cause analysis. And so thinking about both of those, okay, it's sort of a managerial framing, diagnosing, versus a research framing. And how do we keep both of those in our minds at the same time while we do our work? It's very hard to do. The other thing that's important in thinking of the causes of effects is it makes us think of how much variation will an intervention explain. So now we're promoting medical homes. We're promoting ACOs, right? We have the highest cost healthcare systems in the world, right? Okay, so the best you're going to do with medical homes is 4 or 5%, right? ACOs, Tom? You're a bit more pessimistic than me. They're going to bend the cost curve, but they're not going to really do it. And if you started to think about what are the real causes of our cost, maybe you might ask the question, a number of other countries have lower cost healthcare systems because they have much more expansive safety nets that deal with fundamental causes of health, right? So if you start to think about causes of effects, it opens up your world to think of different things you might model rather than just what your grantor might pay you for. The other thing that I think it makes you think about is Feldman and Orlikowski's practice theory. And for me, it's always been Verstehen, especially with teams. So I've asked doctoral students, what do you think is going to happen? They tell me what they hope will happen, right? And then I say, why would anybody in this organization want to do what you're thinking they're wanting to do? And they go, they hadn't even thought about it from the perspective of the doctor, from the patient, from anybody else, right? It's useful to think about it from that perspective, okay? Second thing, like the serendipity of incongruities. So you go to safety net clinics, and I've been to a few, and you meet really incredible doctors, great care coordinators, right? Really well-functioning systems. It's not all safety net clinics, but I've been in a number that are really off the wall in terms of how I think they're organized, right? Then when you do public reporting, they always end up at the bottom of the pool, right? Doesn't fit, right? You got doctors sitting there that are primary care physicians that you say, I would dearly love to have you as my primary care physician. All right? And you tell me that their performance is terrible. Why? What's wrong there? And that's led me recently into working on how we do performance comparison. What's interesting, other than Mark Chasson, I'm not too sure if anybody really ever goes out and validates. They do all their methodological stuff. They label somebody really good. They label them really poor. I'd like to know of any studies you know of that people have actually gone with boots on the ground and validated that with qualitative studies. Okay? Okay, now, the reason that's important is you can harm people. The other thing that I've observed over the years is a number of times I look at reviews that look just in PubMed. So unless the research is published in healthcare organizations, it can't inform us about how teams work. Theory is general, applies to particular situations. Ruth Wagaman has a great paper on Xerox repairmen and incentives that it crosswalks into healthcare directly. Okay, so in other words, look widely for your theory, read the theory, get the table of contents. I do that all the time, and I keep pestering people by emailing things that I think they might like when they come across my desk. Okay, the other thing here that I've noticed over the years and that we've worked on is measurement to fit the concept. So when we were studying ACT teams, we started out with a measure for psychological safety, your standard measures. But after meeting with the teams and talking to them, an ACT team provides care in situ in the community 24 hours a day, 7 days a week. You go out on each visit by yourself, right? Because to have two people go out, you can't afford that. The thing that is most difficult to ask as a team member is to say, I feel real unsafe going on this client encounter. Will somebody accompany me? And you start to realize they're going out on client encounter. One team member we talked to, going out on client encounters in the middle of winter, in the dark, to very rough neighborhoods, and she was having her teenage kids call her at a certain point to make sure she was safe. Okay? So we customized, and also when we asked about interdependence, we said, how much does your work affect the other people in your team? Standard interdependence question. One of the ACT team members said, that's a stupid question. That's a little bit more kindly. But the point was, if we asked that question, everybody would answer 5. She said, you want to ask the question, how closely does your work affect these other people? And then at that point, we got a scale that moved out. So we had to take the psychological safety and interdependence scales, and we had to customize them to fit the particular environment we're studying. And when we do studies in social work, in social settings, I think that's essential. At that point, people yell at us for not having a validated survey instrument we're using, and then you have to deal with the reviewers. Okay? And the other thing, and what studying health teams has taught me. I was blown away when I started to study assertive community treatment teams. Do you know they have a fidelity scale that's been validated in randomized controlled trials? And it is very highly specified. They have a group of people that continue working and improving it, right? And not only do they have that, they have fidelity scales for supported employment, illness management recovery, motivational interviewing, supported housing for each one of the clinical practices. So in other words, when I see an ACT study, I can say, have you measured the dosage of the ACT teams? How often do we, one of the reasons we have mixed results with medical homes is we don't know what the dosage is, right? Developing those fidelity scales is something that, rather than the latest cute finding for policy, we need the infrastructure so the policy researchers can do what they do well. Okay, so that we're not just piling together a bunch of studies that we don't even know what the intervention was when we aggregate them, right? So this is a great avenue for work. Probably unrewarded, but a great avenue for work. Mental health does this really well. It's just amazing to me in that literature how well they do it. Okay. Opportunities for contributions. This one should be me throwing out red meat or really good vegetables, depending on your preferences. Okay. Accountability is our silver bullet, golden bullet, any other bullet word that we use. We even call them accountable care organizations, right? We're going to use self-management to hold individuals accountable, right? I mean, I love the term self-management. Hi, you're a little employee. Just go and do your job for me as being a good patient, and I'll pay you for it, right? You'll have your co-pays and deductibles, right? We have accountable care organizations. We use performance measurement to hold people accountable, right? Okay, and there's a ton of opportunities here on, and I'm going to go through some on the next page, organizational ecology. How does the structure of how we hold people accountable affect the development of firms? And so there's a great ecological study here of the formation and failure of ACOs, which would actually be really good because one of the explanations for ACO performance is the bad ones go out of business, right? And so to understand the ecology of that would be really useful for policy, and you could probably get some good theoretical studies out of that. There's organizational issues here about and I'll talk about that, how do you transmit or incentives down, hold people accountable to make things work in the organization, the same at the clinic. So, contextual effects, the effects of insurance networks and what clinics compete over. I was out interviewing a pediatric clinic, and they told me that such and such a insurer tells all their families with kids to go to some other health system. And this is a clinic that has done really well in developing mental health, autism, care coordination, and all sorts of care for children with special needs. They even have parents who bring their children there and pay out-of-network fees because they're so good. Now, if we think about insurance companies guiding people to preferred providers and networks, right? What does that start to lead the clinics to compete over? Is it to compete over a contract for business with an insurer, or does it lead them to compete over the production of care for kids? How does that affect the way that this institutional structure affect the way that our primary care clinics and our pediatric clinics evolve? And what they're trying to do. How do you win in this game? That'd be a great type of study for me. How does accountability work? If you want the citations, you can email me later. I'll give them all to you. A couple old papers by Pollitt in the public affairs literature, Lerner and Tetlock in the social psych. Okay, we had a discussion with Tom last night about accountability and attribution. And one of the things many people want to attribute every patient. I think we all know people who want to run their own health care, right? Should we hold a doctor accountable for that, right? And also, what do we want to hold primary care clinics accountable for? Let's say a pediatrician has a child show up with children with special health care needs. What do you want them to do? If it was my kid, I want them to punt, to send Children's Hospital to the best in our area, okay? And it's out of my league. I want them to say, this one's out of my league. I don't handle this. If you have a patient come in with sarcoma, do you want the same thing, right? The first thing you want them to do is punt to a national sarcoma center. What do you want to hold them accountable for? You want to hold them accountable for making the right decision to punt quickly, right? Do you want to hold them accountable for the cost of that patient in the sarcoma center? Do we need a theory of accountability in networks? Yes. Because basically medicine is a vast referral game, right? Most of your stable, simple patients stay in the same place, but when we get complicated, we get referred all over the place, right? What would and our theory of accountability has an implicit hierarchical structure to it, right? This would be a biggie here, a theory of accountability in networks and how you manage that and how you set up reward systems on the basis of that could inform CMS. How does the analysis level affect what mechanisms work? Peer is a social mechanism for controlling other people's behavior. There's a large literature in OB on peer effects, right? Second one is we have bureaucratic rules, targets, procedures, clinical pathways, right? Third one is market control, right? Incentives and money, okay? How does the effectiveness of the incentive vary by the level? Down at the clinic level, I bet on peer effects. Peer and bureaucratic. As we move up, I'd argue for incentives and ACOs. Do we have any idea in an ACO how the incentives you apply at the top level to their performance translate down to the shop floor that the doctors are experiencing? No, I don't think so. Again, there is literature from OB and org theory that you could bring in there to help inform it, and that would be a huge contribution, and I think it would go back into the core org journals as well. What I'm interested in right now is performance measurement, risk adjustment, performance comparison. Because I've watched rural providers and safety net providers being labeled as poor performers, right? And I go, look, everything I know about professions and organizations tells me you homogenize care for diabetes. Diabetes is a fairly standard thing. You see a patient that presents, you do a certain set of things, right? So in other words, there shouldn't be, this is performance as a dependent variable. I think it was Jim March and Sutton's paper. Should you expect variance like this or variance like this in these clinics for medical conditions? You shouldn't expect much variance, right? So if you see a lot of variance, why do you see that variance? Could it be neighborhood effects? Could it be people clustering in certain clinics and certain norms? Some people come from certain neighborhoods where people are working 2 or 3 jobs, or there are norms, there's drug trade, there's other things going on. And you cannot risk adjust your way out of this because you end up with an unobserved effect and the random effect of the model. So then how do we have to do performance comparison? And CMS just does risk adjustment, and the rest of how we do performance comparison is not dealt with as well as somebody like David Spiegelhalter at Cambridge would deal with it. It's another huge area. All of these are accountability, right? Okay. For me, I'd love to see some scalable theory. I was talking to Rob once, and he said, how do you keep thinking of these things? And I said, oh, it's all the same, Rob. All the mechanisms are the same, except they manifest themselves at different levels. And so there's a really neat paper by Date, I don't know if I pronounced it right, and Darlow in Org Silence on scalable theory, adaptation, and dissipation. And they were looking at the implementation of shorter service times for ED visits, okay, which is starting in around 2005, 2006, which is a major goal of NHS then. And they started out with an accident and emergency department, their version of an ED department, nested in a hospital, which is nested in a primary care trust, nested in a geographic area, which is nested in the national system. And there are things you have to do. Well, a lot of what happens in an accident and emergency, there are things you can do internally to improve flow, but a lot of the things you have to improve flow deal with interdependencies, like labs getting labs back to you, imaging getting imaging back to you, hospital clearing out beds to the community so you can move people out of the ED, the A&E into the hospital, right? So you have to manage a lot of interdependencies within your local system, right? And that's affected by your wider context. So what they found is at the local level, they had boundary spanning cycles where they worked with all these interdependent people. They had small wins within each unit, and then when they reached their maximum capacity, they had dissipation and reduction of energy. Over time, these efforts dissipated. But what was really neat in their theoretical development is the same mechanism worked all the way up. Now, the downside of this is, as far as I figured reading the paper, they started theorizing about what they wanted to study prior to 2006. They data collected 2006 to 2007, and they wrote 2006 to 2014. And then the paper came out in 2017. You don't get tenure, do you? And it's really nice work. And it's really good theorizing. And so that's the type of thing hopefully you can put on the back burner. And every once in a while, one of these pops up. The other thing to me that I keep thinking of is how at various levels, what we know, why does teams work well? Self-management teams work well if they're giving clear visions, clear directions, the resources they need, authority, right? Could that same model hold for self-management and implementation help? There's a friend of mine who's lost weight many years ago and has kept weight off. And you know how he does it? He has a little book, writes down everything he eats, right? He can see when he goes over his level, right? Is that a quality management control chart? Yeah. Is he basically managing his own life using measurement and data? Is it in a supportive environment, right? So can I take the theories that Dick Hackman has about process improvement and apply them to self-management, and I like the term, the theory of implementation helped by Gallwitzer a little bit more there. Can I use that theory? What about self-managing teams? Can I pop it up a level and use it again? Eleanor Ostrom does this for organizing communities, right? She has the same conclusion, roughly the same conclusions that Hackman and Wagaman do, right? So can I keep using a multi-level theory in the same things? That'd be fun to me. Okay, it's seeing similarities across areas in the mechanisms. However, the way their mechanisms are manifested might be a little bit different. So that's it. Sometimes you don't know where you're going till you get there. So I think the first time I ever had to write up anything about my career, I said, oh gosh, what have I done and who am I? And so then I started to figure this out in a very reflective way. And in the meantime, I've had a great journey. I've met great people and great colleagues. I've had a lot of fun, okay? And I mean, Sarah Kiesler commented to me at Carnegie Mellon, don't worry about all the things that people are going to evaluate you by. Have fun, because at the end of the day, that's what you're left with. And I think that's something to recommend. I'm wondering how we can do theory and engineering better. So it has been discouraging to me to go into some health systems, and you've actually studied teams, and you get treated like you know nothing because, oh, only practitioners know something. No, I think I've been across enough different health systems that I might know something now. And why is it that we aren't, you go to architects, you go to engineers to build your buildings, right? Why don't they come to us? Okay, it's a good question, right? What can we do for them that would be really useful? We started HORA, and then it turned into organizational theory in healthcare after a while. I recommend, if you want to understand why I named it HORA, read Simon, Architecture of Complexity. It has the answer in there. And at the beginning, I would like to see, it would be great if it could, one of the reasons I wanted it is that I felt small groups like OTHC, it's fun. People get together, and Shortell has to buy you dinner, right? He always buys you a good dinner too, right? And it's fun, and you get to interact with people, and you really get to spend time with them. You don't get to in a large venue like this. But in a way, what's missing is we don't have the sub-assemblies. There are people interested in teams. There are people interested in medical homes. There are people interested at a larger level of ACOs, right? Could it be great, wouldn't it be great if there was interaction occurring at that level, email, people talking to each other, little sub-assemblies. And then they would come to the OTHC, as well as presenting their own paper, that you'd be able to take these little sub-assemblies and put it together into a larger assembly of what healthcare is organized like, and really understand how healthcare is organized. So how do you take a community of practice and organize something like that? So people and ideas are bouncing off of each other, so we get serendipity. But then people go back and exploit those ideas and develop them more. And then they bounce back and forth off of each other. And then they put them together more. It's a vision. But it'd be so cool, right? Hanging out with all sorts of neat people all the time. So that's my story. Thank you. Way back there.
I'm loud, I don't have to worry about it. So, I was eating at the restaurant, I do know what I'm eating. So, I'm eating at the restaurant, and at the table next to me, I overhear these two people at the academy saying, qualitative analysis is dead. If you're not doing secondary analysis on textual data, in healthcare, we would call those nodes. If you're not
The question is, Tim's question is, some people are saying qualitative data is dead. There's a greater emphasis on, I'd say, using big data, okay, on using pre-existing data sets. And let's see if I can go down here. No, let me unhide this one. It's a plant. Thanks, Tim. I've heard this, and I've seen people using the big data and also the social media. And actually, and you can do this with natural language processing. You know, and you think about that, and you go, do you find the Higgs boson by just analyzing your existing data? Or do you say, I predict that this thing should be here, this is what I want to measure, this is how I measure it, I'm going to go look for it with the right instrument, right? That's how science advances. You have to have a theory of what you want to measure, right? And it's just a nomological network. We have our concepts, we develop our concepts, then we run our models. We have a theory of measurement that relates the two of those, right? Our existing data. Does electronic health record data tell you anything about social organization of the practice? I might be able to get a little bit if I do audit trails on EMR transactions and in baskets, right? But I don't see anything about face-to-face conversations in the hallway. Does it tell me anything about incentives? Does it tell me anything about the way that clinic's organized? About whether people feel included, whether they can bring up new ideas for creativity or anything else? No. You can mine that data all you want, but you can't answer any questions about organizations. Social media, who uses it, who doesn't use it, right? There's the article, The Google Flu Paradox is problematic. So this is, again, to me, you've got to really be, I love the big data. I like the methods. They're really cool. They're really great for data discovery and data mining. But on the flip side, it's not at all clear to me whether they measure what we want to measure. And science is developing that conceptualization of the relationships between concepts and then developing specific ideas of how to measure it accurately. And could it be cheaper? I mean, natural language processing is a very expensive thing to do when you start to look into it. Could it be cheaper to actually just go and directly measure what you want to measure when you want to measure it? Okay, so I love data mining. I fool around with it a lot, but it doesn't supplant thinking about what we want to explain. And recently there's been this whole thing on shared patient networks, and I sat down one day and I said, okay, what are the generating mechanisms? I've seen papers, hi, shared patients between two doctors measures care coordination. Maybe. Could also measure that my doctor was out of town and I had a problem that another doctor covered for him, right? And okay. It could mean that my doctor retired, or actually one of my primary care physicians became a hospitalist. Okay, I don't know why, but I was mad at him. And the one that retired I was mad at too. And another one got Hodgkin's. That was all right. That's out of his control. Okay. So now I have 4 shared physicians that are due to other things like that. The triage and referral. If I go into my primary care doctor, and actually when I started to see a dermatologist, he looked at me and he said, this is out of my league, go. And he said, and I said, which one? And he said, oh, that one's the one I like. And so I went there, right? And basically the way I deal with my primary care physician and the dermatologist is I tell my primary care physician what the dermatologist cut out last time we were there, okay, or froze, something like that, right? It could be managed care determining a network of who's going to be in that network, right? So what's the meaning of the measure of shared patients? You have no theory of measurement. You do a measurement using your fancy methods, and then you make a claim that it is something, but you've never validated your claim. And there's been some work trying to validate it, but one physician might know another physician, but it might not mean they coordinate care, right? So we need a theory of measurement. Big data doesn't get you there. Qualitative research can give you, I cited the Feldman and Orlikowski and the Beth Betschke work, which I love, about how to understand how things really work in organizations. You don't get there with big data or with secondary data. You get there with boots on the ground doing good research and thinking. You do not get that and that paper I cited on the NHS Scotland accident and emergency from big data, right? And that paper taught me more about how systems work than any ones of the big data analyses I've seen. So that's my response to them. Great fun, have fun, fool around with it, but that's not science. It's cargo cult. And that's a little bit nasty. Until I'm also fairly biased.
Megan, I'll give you another opportunity. I love, first of all, thank you, it's a wonderful talk. And to do science and humor at the same time is very weird. Absolutely wonderful. I think I speak for everybody considering you're chuckling. But, you know, you talked about two opposite situations, and I wonder how you sort of deal with that. On the one hand, you talked about how helpful it is that in the mental health area, they have standard measures for fidelity of the different interventions and see dosing. A moment before that, you were talking about having to revise a standard measure because your teams, it didn't speak to the setting and the context. Like, you know, famous arguments, both are true. Can you talk a little bit about when each works?
For the ACT teams, I was studying ACT teams, and I could rely on their literature that has been really well developed to do that, for their structures. What I invented for them was a teamwork in ACT that I had to customize for them. If it's a behavioral measure, I'm pretty happy with using any type of behavioral measure, observational measure. If it's a measure like psychological safety, what you run into is floor and ceiling effects. So as I said with the interdependence, I say the work that you do affects other people in the team. In an ACT team, it's 10 to 12 people. They meet every day. They discuss all the clients every day. Anybody can cover any client at any time. So they all affect each other a lot. Okay, if I ask that question. So then you have to customize. So what you're trying to do is aim and ask, in this setting, does this scale that I'm using really give me the ceiling that I want? And so this was actually, with some colleagues in England, they used a climate scale that was validated across industries. They used it in healthcare, and they got no variation. It's every setting, and it's also looking as to what you're trying to measure and whether or not I have to customize this question to your particular environment. So I would probably have a hunch that if I was doing a patient safety measure in hospital settings, I would probably consider doing a NICU different than an ICU, different than sort of any other type of ward. And this is going to drive your viewer. Then when you run your data, the first thing you have to do is you have to do the psychometrics. You have to demonstrate the measures work together, right? And you have to hope that you've done it right. Or if you want to, you can do a preliminary study to do that. But what you're trying to do is get measurement precision. And if you use a validated measure that isn't for your setting, you do not measure what you want to measure. With the ACT study, because we really worried about this, we're getting significant effects on relatively small sample sizes because we measured exactly the concept we wanted to measure. Now, you're going to submit papers, and the reviewers will say you didn't submit the validated scale. And you pull your hair out. I mean, okay, and then you try to make your arguments, right? But you advance the science by doing the measurement correctly to begin with. That's our theory of measurement, right? So life is tough. Get over it. Any others? Scared them all off. So thank you very much. Now I can relax.
Thank you so much for
Okay.